Acute myeloid leukemia, or AML, is a devastating disease with poor overall survival. Access to precision medicine is revolutionizing AML care and driving an increase in the use of next-generation sequencing, or NGS, to determine the genomic profile of patients with AML. Advanced analysis into the interplay between mutational status for multiple genes is granting access to new targeted and precision medicine treatment options with improved outcomes. Multiple hurdles exist within the clinical diagnostic testing ecosystem that prevent patients from benefiting from many of these advances in precision medicine. Harnessing the power of patient data on an interactive network platform that navigates the patient journey in an efficient manner and in collaboration with multiple stakeholders, such as pharmaceutical companies, labs, and regulators, may eliminate these hurdles. Diagnostics, a precision diagnostics commercialization company for the global pharmaceutical industry, has amassed over 227 million real-world patient records from 35 countries in its proprietary Global Diagnostic Index database. By merging these patient data into its soon-to-be-launched interactive network platform called DXRX, Diagnostics offers a solution to the broken clinical diagnostic testing ecosystem, reducing patient leakage due to suboptimal testing. We used the Global Diagnostics Diagnostic Index database from 2017 to 2019 to analyze a cohort of 984 AML patients with a TP53 mutation detected by NGS. We analyzed the effect of FLT3, a common TP53 co-mutant, on 5-year overall survival, common upstream regulators, and common activation pathways via gene set enrichment analysis, or GSEA. The rate of NGS adoption was generated from Center for Medicare Services, or CMS, data between 2017 and 2019. We noted a twofold increase in the average routine clinical practice uptake of NGS in CMS patients. In our cohort, 15% had a TP53 mutation. In those patients with a TP53 mutation, significant negative associations were observed with mutations in 7 other genes: ASXL1, CEBPA, FLT3, IDH1, NRAS, RUNX1, and TET2. We did not observe any statistically significant differences in TP53 mutation and other gene mutation rates between diagnosis and relapse refractory AML time points because of the low numbers of patients. One possible explanation for these results is that double mutants result in synthetic lethality, leading to a low clonal population. The second possibility is that co-mutated clones escape immune surveillance and regulation, resulting in particularly aggressive leukemias with lower overall survival. Subsequent investigation supports the possibility of particularly aggressive leukemias, resulting in lower overall survival. Using FLT3 as an example, Kaplan-Meier estimators and Cox regression analysis adjusted for sex and age affirm that prognosis for AML patients with TP53 mutations is significantly worse than double wild-type TP53 wild-type or FLT3 mutant. Furthermore, patients with a FLT3 mutation were expected to have significantly lower survival at 5 years relative to wild-type AML patients. Survival curves for patients with double FLT3 TP53 mutations were excluded due to low numbers of patients. There were no common synergistic upstream regulators of both TP53 and FLT3. However, there were significant common downstream targets. FLT3 represses TP53 via ROS-PI3K, AKT MDM2, and is dysregulated with either FLT3 TP53 mutation. GSEA analysis also suggests that both TP53 mutant and FLT3 mutant pathways both act to suppress apoptosis and enhance survival signaling. TP53 mutation and co-mutations are relatively stable, which has implications for testing algorithms and clinical utility as a marker of minimal residual disease, or MRD. Although a clinical trial may not be feasible due to low numbers of patients, a TP53 antagonist and targeted therapy may be a valuable treatment option in rare cases where co-mutation does exist.